Hi, good evening. I'm Lonnie Stonich, the Executive Director of FAN, and I am so excited to welcome you to tonight's conversation between Dr. Thomas Insel and Dr. David Schreiber. FAN is a nonprofit organization that presents a high-quality speaker series offered free to the public on a wide variety of topics, including human development, mental health, social justice, and education, among others. We have over 175 videos of past events archived on our website and our YouTube channel, so please be sure to explore. And now for some introductions. Dr. Thomas Insel served as director of the National Institute of Mental Health from 2002 to 2015. He is the co-founder of MindStrong Health, a Silicon Valley startup building tools for people with serious mental illness, and a co-founder of Humanist Care, a therapeutic online community for recovery. A child, adolescent, and adult psychiatrist, Dr. David Schreiber is the CEO and co-founder of Compass Health Center and Compass Virtual. Compass is the largest provider of intensive, non-hospital-based psychiatric care in Illinois, with brick and mortar locations in Chicago, Northbrook, Oak Brook, and in virtual settings statewide. And now let's welcome Dr. Thomas Insel and Dr. David Schreiber.
Thank you, Lonnie. Tom, if you don't mind, just before we get started, I just want to give some gratitude out. One, I just want to give some gratitude out to George Vredenberg and his daughter-in-law, Janine Vredenberg. Both of them introduced us a year and a half ago under the context of two people interested in moving the needle in mental health and wanting us to get together. So I thank them for that introduction. To Fan and Lonnie, as always, appreciate your mission, your passion to better the community we live in through education. And I thank them for that mission. And of course, Tom, I know we're going to be talking about your book tonight. I know the last thing on your mind is selling your book, but you use your book as a conduit for your mission. And I thank you for your dedication and the time tonight to engage us all. So I want to start off by talking about, obviously, the book and recognizing that there was a lot of people on this Zoom tonight who come from across the country, who come from across the globe, who comes with a variety of professional experiences and their own personal experiences. But one commonality we have is we all been touched by the mental health crisis. So knowing that, what was your target audience for this book?
Well, first, David, real pleasure to be here with you. And we've been talking on and off for the last few weeks and getting to know each other a bit. And it's been great. It's really been fun to have an opportunity now to broaden that conversation. And great to be here. You know, FAN is doing something really spectacular. It's amazing how many sessions there have been. I feel like I'm the caboose on a very long and busy train here. So happy to be part of it. Look, the book was evolved. When I started, it wasn't really clear who I was writing for. I was trying to really write for myself, trying to figure something out that didn't make sense to me. But ultimately, as I put the story together and started to think about the arc of the narrative I wanted to tell, I realized that the main audience was going to be the parents of a 21-year-old with a psychotic illness who were feeling like they didn't see a way forward and were feeling hopeless about their son or daughter's future. And what struck me so much in the work I was doing for the book was how families, and particularly parents, but families generally, have become the navigators, the caretakers, the first responders. They do so much in this area, and yet the healthcare system often cuts them out, and they don't get included in a way that really honors what they can bring to the set of solutions that their loved ones need. And so I was thinking in writing the book, gosh, someone's got to speak to them, and they've got to be part of hearing what do we know about this problem and what are the solutions. And so a huge part of it for me was trying to give them hope that we actually do have things that work. We know how to do this, and now we've got to get together and make it happen.
And obviously, as we think about our patients, you could have wrote this book and produced this book at any point, you know, and it would have relevance. But now it seems even that much more relevant than ever. And I say it in the context of our patients have been always suffering. But there is a little difference of a suffering today. And I don't want to say that one suffering has more of a subjective value than the other. But I will say that it does feel different today. And I say that in the context of recognizing the burnt out atmosphere we live in today, which I've never seen beforehand, where patients are burnt out, parents are burnt out, support systems are burnt out, those who are providing are burnt out. You talk a lot about solutions in the book. How do you talk about solutions in a patient population today that is suffering as always, but also in a burnt out system?
So let me get you to unpack that a little bit more. When you think about burnt out, you mean the workforce generally, or you mean the lack of capacity? What's the piece that you think is different in 2022 compared to 2012 or even 2019?
I think the burnt out of the system. I think the burnt out of those who are providing, and also the parents themselves. The parents themselves seem to be more burnt out in trying to manage life in general. And when you have other crises enters your life, it gets that much more complicated.
Well, I guess we're going to talk about COVID, right? I mean, it's kind of the topic of the last 2.5 years. It's hard not to talk about it. And you know, the impacts have just been so extraordinary. I'm feeling that a little personally right now because I'm supposed to be in Washington, D.C. today, but my granddaughter became very ill, a 7-year-old with COVID and positive on the weekend after I'd been holding her on my lap for all the way through a Little League game. And so that sort of changed my week, not only because I couldn't travel for 5 days, but because also all her brothers and sisters have been quarantining with us while her mom takes care of her. So yeah, it certainly has brought a kind of uncertainty to all of our lives and an unpredictability about, you know, at some point you think, do I really want to schedule this trip because it may not happen anyway? So I think we're all feeling that in so many ways, just not just the uncertainty, but just the way in which there's been so much loss, you know, loss of people, loss of opportunity, you know, the kids who missed their graduations, the people who lost the opportunity to do research or to get care or to go ahead in their jobs. I mean, it's just been a remarkable period for so many people. And I often think about especially for my grandkids, that in some ways, this is a defining moment for their childhood. They're really the COVID generation. And this will be something they will live with and will leave a mark. And I'm not sure what kind of mark, whether that's a mark of resilience or a mark of unpredictability and uncertainty. I don't know, but I think all of us are going to be watching for what this does. One thing we do know, and I think this is where you're going with your question, is that COVID seems to have had the biggest infectious disease impact on people over 50 and the biggest psychological impact on people under 30. It's really stunning. I mean, if you just look at the numbers we've had 1 million deaths in the United States. There are 7,131 deaths for people under 30 from COVID. And yet, in that same period of time, if you look at deaths of despair, suicides, drug overdoses, they're like roughly 75,000. So we have essentially 10 times more mortality for young people from COVID than we have, that is people under 30, than we have from the infectious disease itself. And the lesson here is that they're really carrying a lot of the psychological burden of this pandemic. And we know how that plays out. We knew in 1918 this was true. It's been true in other major health crises, that there's a long tail. The psychological impact goes on not just for weeks and months, but sometimes for years. So I think we're still at the very beginning of that aspect of the pandemic. So to your burnout question, it's not, we've got a ways to go. And I think we're all going to have to figure out how we wade through this, because it's even if the viral part of the pandemic subsides, which it really hasn't yet, But even if that does, we're still dealing with the psychological consequences.
And that's something that I've always been concerned about, is that we know in trauma that a lot of trauma doesn't present itself right away. It's 6 months later, it's a year later. And as we hopefully move out of COVID, and like you said, we're not out of it yet, we have to keep a very wide open approach to people might seem to be doing okay today, but in 6 months for a year to now, we still got to keep a wide open understanding of what might be in the horizon. But one of the things that you said to me at our last conversation, which really resonated, you said to me you are pathologically optimistic. And I've never heard that before. And I mean, I called myself cautiously optimistic. But I thought about that, and I thought about different people in my life who are probably fit into that same characteristic. And what's incredible about that characteristic is that those people tend to be very empathic. And when I think about it, I said, you talk about the backdrop here of suicide. I mean, I think over 47,000 suicides, recent numbers, over 100,000 overdoses. It's hard to find silver linings. But somebody with the optimism that you have, talk to me a little bit about the silver linings that you find in the mental health care system, and even somebody like you still struggling with.
Okay, well, so there are silver linings to COVID. I'm reluctant to say this, but I do think that it has changed the way we provide mental health care. And certainly it's all gone remote. It's stimulated a huge amount of innovation. And I think there's going to be a good story to tell. I don't know where it will end up, but the mental health care system in 2022 looks really different than the system of 2019. I mean, there is greater access. I think there's greater opportunities. There's greater demands on the system as well. But we've now figured out lots of ways to get people into therapy, to get the medication that weren't really available 3 years ago. So those are, that's a good thing. Look, the issue for me, and this is kind of why I felt it was so important to write the book, is that we do have good solutions for almost, maybe not all the issues and the problems in the current mental health crisis, but it's important to know that this mental health crisis, and I think it is a crisis, is really, it's not like the COVID crisis. It's not like we have this massive increase in prevalence of a previously unknown problem. This is a crisis of care. This is a crisis largely because we're not providing the kind of care that we know how to provide. I mean, we do know that between medications, psychological treatments, some of the new neurotechnologies, and most of all, the rehabilitative care that we are able to provide, the sort of psychosocial supports, that people can recover. We know that these things work. We've known that for decades. And yet we aren't delivering on that. So my optimism is that, like, we have the answers. They're hiding in plain sight. It's simply a matter of waking people up to this and getting them to commit. I think it's much harder to stop global warming or climate change. Those are really hard problems. This one is actually quite doable in a relatively short time if we simply say, look, these are the 5 things that we know we need to put together. Let's do it. Let's make it happen. Let's scale it. Let's pay for it. Right now, a lot of the things that we know are really helpful, we don't pay for, and so they don't get done. That's a fixable problem.
So what are you discouraged by?
Discouraged? What am I discouraged by? Just the slowness with which change happens. I work in the tech industry, or have for the last few years, and it goes at a completely different pace. I mean, it's just so striking to me that when people talk about tech and, whether tech will transform mental health, and they say, well, we'll have these apps and, but maybe the apps aren't that good. I always think that it's not about the apps. It's about the culture of tech. That in the tech world, people know how to get stuff done. They know how to involve the consumer right at the very beginning. You don't ever build a product without what's called UX, user experience. That's a fundamental principle. In mental health, we don't do that. We build things for payers or providers. We don't build them for the users, for the consumer. So tech we can learn a lot from that. And we haven't. I think we just haven't. Instead, I think we're really continuing to do a lot of what we've done in the past. And some of this is simply providing the incentives. It's moving the way that people get paid. It's moving who gets supported in the workforce. And that's been slow. It's been very slow to change a system that actually doesn't work all that well for anybody.
But one thing is that, look, we don't sell widgets, right? And I do find sometimes tech moves quickly, but they're also solving for sometimes a different problem. And sometimes, in healthcare, when you solve too quickly, there's an aftermath that you have to pay for as well. Obviously, there's a balance in between. And I think about it when before COVID start, us at Compass, we were invested in virtual. And it was fascinating to me. This is probably 6 to 8 months beforehand. And I was talking to the payers, the politicians, the healthcare system. Nobody wanted to talk about it. Everyone's like, it sounds interesting, but they weren't very interested in it. And here COVID happens, and we were forced to do something overnight and look at what improvement we've had with access on some level. I don't want to oversell the access, but on some level, we've had such significance. But one of the things that kind of reminds me also, which I want to come back to your book on, us as doctors, we want to do things. We want to get things done. We want to improve the lives of those who are suffering. And one of the things that really resonated, that I found very profound, was the quote you had from Anne Sexton, who was a famous poet. And I don't remember exactly, but the paraphrase was something like referring to her doctors, and something about her doctors leave their home in the morning on horses, and God returns them at the end of the day by foot. Can you talk about that a little bit?
Yeah. So that's part of a chapter in the book on the title of the chapter is Beyond Stigma. But what the chapter is really about is just how humbling it is to try to help people who may not want help and yet really need it, and how difficult that is. It's actually not a problem that we have so much in the world of cancer, heart disease, diabetes. People who have those illnesses and who are really sick are usually pretty eager to get help and get well. But in mental health, often the sicker you are, the less likely you are to accept help or even recognize that you need it. That's hard because you get into the conflict around trying to provide care for somebody who's not looking for care, and sometimes having to give that care involuntarily. You get into incarceration, you get into involuntary hospitalization. I mean, it's a lot of places that we don't want to go as healers or as physicians, and yet that's the real challenge of these illnesses, is they force us to go there at times if we want to really help somebody recover. I got into a way of thinking about this that kind of left me feeling like, a kind of an ancient construct, that the people with psychotic illnesses almost had a kind of demonic possession. They were just being taken over by this illness. But as there's a wonderful title last week in the New York Times that somebody wrote. It said something like, dementia is where my mother lives. It's not who she is. And that's kind of how I feel about schizophrenia. It's where people may live, but it's not who they are. So to the extent that we can separate those things and realize that we may need to treat this illness, even when the illness doesn't want to be treated, because the person behind that ultimately will recover and will need that. And you hear that over and over again from people who go through that journey and who get well. Like, thank God you didn't listen to me when I said stay away. Thank God I actually got care. But in the moment, it is difficult and it's humbling. And that is where that quote fits in, because we come in with the best of intentions, but we as Anne Sexton says, we come home on foot. It's not easy.
But I also thought it would have resonated is how humbling it is to us as doctors too.
Mm-hmm.
Is that us as psychiatrists, different than maybe our colleagues in surgery or other kind of fields, is how humbling our illness can be for us, and how I think in mental health in particular, why it's so important to have partnership. And, it reminds me of, we talk a lot about it takes a village. And when I was thinking about it after that poem, after that quote, we talked about what does it really mean to take a village? It's not about taking a lot of people, but it's about taking a lot of people who have commonality in their interests and having them work together, which makes a difference. And I think that in mental health is where we need to strengthen, is on the partnership side. Can you talk a little bit about partnerships where you've seen success happen, where people really have been working together in that commonality?
Yeah, well, I talk about a bunch of different examples of this in the book. One of the things I was trying to figure out is like, who does this really well? Show me where do people recover consistently, and where do they avoid incarceration and hospitalization? I mean, in a weird way, one answer to that question is 1975. Because when I started my career, I think we did better than we do today in creating those partnerships and in working well. We had more capacity. We still had hospitals. We had intensive outpatient and day hospitals. We had clinics, community clinics. We had a lot of resources that allowed people to work together, and we had very much a team effort. You still see that in parts of Europe. There are places in northern Italy that, like Trieste and Verona, that have built out really good mental health care systems that are all about partnership and teamwork. And by the way, a really critical piece of who's on the team is the family and the individual. And one of the things that you see much more in Europe than you see here in the US is giving the person you're trying to help some real agency in deciding what that help could and should look like. Here we have a very expert-driven system. You get sick, you go to the doctor writes a prescription, and either you decide to take it or you don't. But there's a different way of doing this. It's really been pioneered in Finland and now in the Netherlands, of sort of bringing people together in what's called a support group. It's really like the people who have your back. If you're the 21-year-old with schizophrenia, these are the people who are going to be there to make sure you recover, you finish college, you get a job, you have a girlfriend, whatever it is that you think is most important for your recovery. You lay that out, and they are there to help you. And so the team there is really driven by the person with the illness. He or she is the quarterback. They call the plays, and then they've got a whole bunch of people around them, some professionals, some not, to make sure that they get to where they want to go. That's a kind of perspective I don't see that often in the States, but it's something that I think we can learn from, particularly Northern Europe, where it's become much more prevalent, and I think more successful.
I 100% agree. I mean, that's one of the priorities at Compass, where we mandate people come into our programs. Anybody under 18 has to involve themselves in family therapy. It's the glue. And it always amazes me as a provider how many people leave out the family and recognize that, I mean, you can't get success without bringing the family, when you can, at least. Under 18, you could do it. Obviously, it's a little bit different when people are older. But one of the things you talked about was going back to 1975. And that was one of the things that I really enjoyed about the book, is that us as doctors often always looking forward. And sometimes if we don't take a good history and we don't look at the past, then we miss opportunities and we miss a diagnosis. And one of the things that you went back on, you talked about 1975, but you also talked about some parts of our past that are not glorified, are probably our low points, and things that personally I find embarrassing to the field. And you talked about lobotomy. And I bring this up because when you think about it, how tragic of a time that was. And I don't believe any of those people who are doing it were doing it out of were evil in any capacity. In fact, the person who created it, we nominated for, won the Nobel Prize, in fact. But the fact is that at that time, the treatment was probably worse than the illness, which is something we should always avoid as doctors. But it also made me wonder, we look at that time with great discouragement and sadness, Is there anything we're doing today as providers that the next generation will say, what were they thinking?
Oh, absolutely. Actually, David, we should both answer this question. I'd love to hear your thoughts about it. The one that I'm most obsessed with, and I do think it will be just unconscionable when our grandchildren find out that we spent so much time incarcerating people with brain disorders, particularly mental illnesses, that instead of having them in a care system, we had them in the criminal justice system, that they went in for punishment instead of care, as if they had, as if they'd committed a crime for having this illness. That's actually the way that modern psychiatry started, in the first half of the 19th century. There were people with what we now call mental illness who were often chained in prisons and jails. And it was Dorothea Dix in the United States and Philippe Pinel in France and William Tuke in England who said, that's horrific. How could we possibly be incarcerating people? They need to be in hospitals. And that was the beginning of the whole state hospital system in the United States and the asylums that were developed from 1850 to 1950. I think now what we've done is kind of gone back there. Tonight, there will be 350,000 people with serious mental illness who will be in a jail or a prison someplace in the United States, and about 35,000 who are going to be in a public hospital like the ones we used to have. Those weren't great, by the way. I'm not suggesting we need to go back there, but we ought to do better than incarceration for people particularly with serious mental illness. And I just think our grandchildren are going to think, what on earth were you thinking? I've called this actually, in some ways, that we're in sort of the Jim Crow era for mental health, because not only is this happening, but nobody seems to know about it, and everybody seems to be kind of unwilling to look at it. We have trans-institutionalized. We've gone from closing the whole healthcare system in the public arena in the States, and we've moved everybody into jails and prisons in a way which it's unconscionable. What would you say when you look at the things that we're doing now that we'll be horrified by 30 years from now?
Well, I think it's this notion of, I always try to keep mind of, again, is the treatment shouldn't be worse than illness. And I think, somebody who's treated a lot of severely mentally ill over the years, us as doctors, we want to solve problems and we want to help. But sometimes we don't stop and we keep throwing things at it and we keep throwing solutions at it. And sometimes it's medication. And we don't hear our patients when they're saying, hey, I don't like this side effect. I don't like how it makes me feel. And we blame them then for their compliance, but we just weren't listening to them. And I think that's an important notion that we have to always keep in mind when we're treating, is make sure we understand what the illness is and don't create another problem that's going to make it more complicated for them. And I think that too often we do sometimes as providers.
Yeah, I guess if we're going to pile on here, because there are probably so many things I'm going to have to explain to my grandchildren, which I'm not looking forward to. But the other one I think is the way in which we have bought into this idea that there's going to be a medication for mental illness that will be the solution. And look, I get that. I think it's really makes sense in the world of infectious disease and in a bunch of other medical areas where we can identify a molecular cause and we can develop a small molecule for that particular target. And we can't treat or even cure the problem. And we've done this really well with antibiotics for bacterial infections. I just think at this point, the evidence we have is that that's not what our medications do for mental illness. They may be helpful, but they're not cures. And by themselves, that's not care. That's medicine, but it's not care. What people need is often medication plus psychological treatments, psychosocial supports, a bunch of other things. And I'm particularly concerned about this. And it's one of those reasons why I think, all right, this is going to be hard to explain to anybody in the future, because we're spending $4 trillion, $4 trillion on healthcare in the United States today. It's 18% of our GDP, and it pays for all the medicines. But the things that really work for someone with a serious mental illness, a clubhouse, the ACT teams, supported employment, supportive housing, all of those supports that we know are really essential for people to recover. They're the things that really allow people with an illness like schizophrenia to be able to finish school, get to work, have a family, and actually thrive. They're not part of healthcare. So the people, the places, the nonprofits that are building clubhouses and providing ACT teams, they hold bake sales, right? Or maybe a gala to try to raise some funds. And they're always working on a shoestring. That's just not right. That's just not right. If in an area where we're spending $4 trillion, we ought to be putting some of that money into the things that actually are working to help people recover, instead of continually feeding this cycle of crisis care in and out of hospitals on more and more expensive medications, when none of that actually leads to recovery. And much of it can be averted by doing things that are far less expensive. That's going to be hard to explain. The question is, are we going to be able to fix that in the near term? And what will it take to fix it? That's what the book's about. It's sort of saying, hey, that's the path. We know what to do. These things are hiding in plain sight. We've known about them for 3 or 4 decades. Time to start paying for them. Time to actually begin doing what works.
Why does that discrepancy exist? Why are we always chasing the medication? What is the statistics? In your book, you talked about 34 million adults on medication, 4.5 million adolescents on medication. Why are so many people are coming to us for medication and not the other things that also are effective and arguably more effective?
Well, I'm not against medication, right? I think it's sometimes, rarely is it enough. So I think it's often necessary, but it's rarely sufficient. Look, I often tell people, it's like, if you want to learn to play the violin and you have a bad tremor, you do need to get something to control that tremor. But controlling the tremor doesn't teach you to play the violin. There's a whole bunch of work you need to do, and it takes time and effort, which a lot of people don't want to do. You know, they'd rather simply take a pill in the hope that pretty quickly they can start to play some very complicated sonata. I wish there's no medicine for that. So again, you know, we do have psychological treatments that are very effective. People often don't want to do the work that's required for that. Or sometimes they do want to do it and they can't find somebody to help them through it. We don't always have the workforce we need. So there are a lot of explanations why it hasn't happened. But the reality is, we have the system of care that we pay for. We have exactly the system that we incentivize. And what we pay for most of all is the medical care. And the most expensive part of that, oddly enough, is what we're most likely to pay for, which is emergency room visits, hospitalization, sometimes expensive medications, although in mental health, medications are kind of now mostly generic. They're not that expensive. But that's the medical model that we built, and that's what we're invested in. I'm just telling you, it's not enough. I mean, I think it is important, and we want to continue that. And people with mental illness deserve the best in the way of medical care, but they need a lot more. The way I actually say it in the book, and it took me a long time to come around to this, because our field is so polarized on this issue. Either you believe in recovery or you believe in the medical model. And the reality is you need both. You need both. The problem is medical. These are brain disorders, and the people with them deserve the same rigor of care, the same reimbursement, the same kind of healthcare that anybody else deserves. But the solutions are social, they're environmental, they're even political. They're much more than what gets included in the medical model. You need something much more extensive if people are going to recover. And that's ultimately what we should care about.
You say the mental health crisis today is a crisis of care. I'm curious to know what define that better, because I have my own notion about what it means.
Yeah, for me, it means that we're just not doing the things that work, right? And I break in the book, I break that down into a couple of different categories. There's a quantity problem that we simply don't have. We don't have the beds, we don't have the community clinics, we don't have the crisis services like the mobile vans and the drop-off centers and all of those things that we know are very helpful and save lives. We don't have them. We haven't invested in them. So there's too little. Oddly enough, most people say we don't have the workforce. We don't have enough people, therapists. We have a lot of those, but they're often in the wrong place or they're not trained to do the right things. So that's an issue too. Quantity problem, and there's a quality problem. And the quality problem is that when people do go to get care, often what they get is very fragmented. It may not have a scientific basis to it. And because there's no measurement, we don't improve care as we go. So we don't learn in the way that we would in treating diabetes or hypertension or a lot of other medical problems. And that's a big issue for us, is that quality has not improved. It's sort of interesting to me because when you talk to individual practitioners, individual providers, whether they're on the medical side or more on the therapy side, they're doing good stuff and they work really hard and they're really compassionate and they care about the right things. And in fact, the people they see are getting better often, but it doesn't show up at a population level. So in spite of more people getting more care, we're spending more money. We had so much progress on the science and the development of new therapies. The outcomes are all getting worse, and that's at a population level. So suicide continues to increase. It's a little lower today than it was 2 years ago, but it's still 30% above where it was in 2000. We see more homelessness, more unemployment. On almost any measure of disability, the numbers are going in the wrong direction. So for me, the crisis of care is that gap between what each of us as individual providers may experience and what's happening at a population level, where the public health numbers suggest that whatever it is we're doing, it's not bending the curve in the right direction.
And no, I think it is that bifurcation that's happening. We have a lot of money going into treating what we'll call the worried well. Those who are struggling, but not struggling to the point of debilitation, that they are functioning in their lives. And there's a lot of people who could do it. But there's a real movement that's happening from those who are managing crisis into a system where a lot of people can do it. And what ends up happening, if you look at COVID, right? I mean, when we looked at the metrics for COVID and when it got really concerning was when, where are the ICU beds? Where are the respirators? And the parallel with mental health is, where are those beds? Where are the equivalent of the respirators and the ICU beds? So those who really severely mentally ill, who really are struggling, how do we get them the services they need? And there doesn't seem to be enough resources going into that population.
Yeah, that's where I spend a lot of my time, is thinking about the needs of the most severe patients who have the greatest needs, the severe people with severe mental illness or serious mental illness, SMI. And that's a lot of what's in the book. And it's for just that reason, is that, whether you look at innovation or you look at where the workforce is focused, or you look at even where the health system is focused, they're left out, they're neglected, and they always have been. And that's on us, right? They're the ones who end up incarcerated, they end up homeless, they die 20 to 25 years earlier than they should. All of that could be averted in a better world. All of that would be different. And we know what to do. And we know the things that really matter and that work, but we're not doing them. So it comes back to this same issue. It's a little bit like this, what happened in COVID. At least for me, there were several amazing insights, but to realize that we got really good at developing vaccines and we were really bad at delivering vaccination. And it's kind of like that disparity, right? So I think from my time at NIMH, where we did the science, we got really good at developing treatments that help. And we've been really bad at deploying them at scale and making sure that people who need them the most are getting them where they need them. Some of this, of course, people always say, well, it's a problem of access. Yeah, it is to some extent. But I think a bigger issue, which we don't talk about in the mental health space, is engagement. And actually, that's the reason it took me a long time, most of the book, to figure that. I wrote the book to figure this out because I couldn't understand, why is everybody doing so well individually and we're doing so lousy at a population level? Like, how do you square that? Like, I couldn't make sense of that. And the answer in part is that it's what I call the 40-40-30 rule, that only about 40% of people who could and should be in care are in care, right? Most people who would benefit actually are never in care. We never see them. Of the 40% we do see, only about 40% of them, according to NIMH, get optimal or get even minimally adequate care. And of those, about a third get well, a third respond, and a third don't do so well. So you start to do the math, you take 30% of 40% of 40%, you're down to 5 or 6% of the population actually responding in the way we want. And we can bump that up to 6 or 7 or 8%. Hey, the problem is really way upstream. It's the fact that we haven't engaged 60% of the people that we should. They're not buying what we sell. And part of what I think we need to figure out is, how do we engage that population so we're not just seeing them either after a suicide or when they're in the last stages of a very severe illness and they end up in the emergency room, very complicated problems. How do we actually engage people much earlier? And how do we get them something that helps them at a time when they might actually be willing to accept it, because they won't be when they're in stage 4 psychosis.
So then who has to engage more?
Yeah.
One of the things you talk about in the book, you talk about government taking 4 decades of not showing leadership. You talked about also society having kind of a Jekyll and Hyde experience with mental health. So who has to engage more?
Well, there's a bunch of things we need to do, right? So and I kind of put it into 2 buckets. There's a lot we can do to help people recover. And we've talked about that. The psychosocial treatments like ACT teams and clubhouses and supported housing and supported employment, all of that. The other piece is what we'll broadly call prevention. It's a funky word. It's not so easy to do, but it is going to be critical for us to begin to move upstream, not like a few months, but a few decades. So these disorders broadly, generally, are disorders of childhood. They're very different than anything else in medicine. Almost everything else we do in medicine belongs to the second half of life. 75% of people with mental illness have onset before age 25. 75% before age 25. That means that these are really the chronic disorders of childhood, and yet we don't see them until much later. So how do we manage that? Well, the problem for us is we're waiting for them to show up instead of meeting them where they are. Where are they? Well, they're in schools, they're in families. A lot of them are online. There's a huge amount of stuff, a huge amount of psychopathology playing out online. That's where people go if you're 17 and you're struggling. But we're not there. And so we ought to be thinking, like, what does the mental health system need to look like? Or maybe it's not a system, and maybe we don't even call it mental health, but how do we engage much earlier? And it is all about engagement by meeting people where they are and giving them what they want at a time when they really need it. And that can happen in schools, and it can happen in lots of other places. We're having that conversation in a big way here in California. The governor and the legislature has now committed $4.4 billion for a youth mental health effort to make schools the center of gravity for our mental health care. And realizing that the only way we're really going to be able to solve a lot of these issues is to get way, way out ahead of them and begin to engage people in middle school. Give them the tools they need for resilience. Give them what they need to understand when they do need something more than what's available within the school system, and then build out the supports around them. And we can certainly do that with a new workforce that can actually help. So I think, again, pathologically optimistic, but there is a solution here. But other than in California, I haven't seen a lot of effort to rethink this problem as one that's really focused on moving upstream and getting ahead of it.
One of the things that rethinking things, and one of the things that I was excited to see in the book you talked about with John Cacioppo. John Cacioppo and the science behind loneliness. And I think it's one of those things that we really underappreciate sometimes as a symptom of depression and miss that opportunity. One of the things that really resonated was, what really was powerful, you talked about a Cigna study of 20,000 people, and a fifth of them, adults, talked about never having in their lives deep connection. Talking about never in their lives, not just a moment in time, never in lives having a deep connection. And it's that understanding and appreciation are ways in where we can identify risk, people at risk at a much earlier on. Can you talk a little bit about John Cacioppo and his work?
Yeah, well, John was the person who really pioneered the study of social behavior in humans and came up with this idea that the need to connect is like a biological drive as much as hunger or thirst or anything else. I spent most of my career working on that problem, but not in humans, but in laboratory animals where we could, or sometimes field animals, we did field studies as well, where we could begin to define the brain circuitry and the molecular basis for this. So I'm obviously a big believer, and I came at this problem with really 30 years of trying to understand the biology of social behavior. It's a huge issue, which I think has been neglected. I was fascinated. The New York Times ran a piece this weekend on the Hearing Voices movement, which is pretty interesting, and it's something that a lot of people listening in may have read. And I was just fascinated in reading that. What struck me was that the value of the movement wasn't anything about stopping medications or giving life to these hallucinations. It was doing it together. It was joining with other people to share this experience. And for those with serious mental illness, they never get that. They don't have that fraternity. They don't have people who have their back. They don't have a social connection or a social network. And that's what clubhouses do. That's what you can do with the kinds of teams that we're putting in place to be able to support them. That's where peers are incredibly important. And the whole peer movement is going to be fantastic, I think, for changing what we do in the mental health space, because it not only gives somebody help by connecting them to somebody, it gives people with lived experience the opportunity to give help. And that is very empowering and really important, and a big, big part of recovery. I talked about the 3 Ps: people, place, and purpose. You need social connection. You need a safe place to recover. But most of all, you need a purpose. You need to take this experience and make it meaningful and find something that gives you something to wake up for, something to care about, something to recover for. And that's one of the places where I think we can do so much better. Actually, on all 3 of those Ps, but the loneliness piece, that first one of social connection, that's really where you got to start. And by the way, if you haven't visited a clubhouse or you haven't seen how those kinds of facilities can just transform people and give them enormous a sense of hope because they've connected to other people, it's really worth visiting. And I must say that I think one of the most overlooked things in psychiatry is the devastation just from social isolation and loneliness. And that's entirely fixable.
I know we're coming down to the end of the hour, and I know there's some questions waiting. but I want to make sure I capture your optimism. I know when we talked about this book and the tone of the book, it's so easy for people to assume without reading the book a level of pessimism, a level of despair. But there's a lot of optimism in this book, and there's a lot of things to really be excited about where things can go. I like to one of my favorite, I don't know if it was a chapter title, but you talked about not all complex problems need complex solutions. And can you end this discussion with a little bit of the story of the town of Geel or the friendship bench, which I think is a really good opportunity to talk about. We don't have to make our solutions so complicated.
Yeah, well, thanks, David. Gosh, you really read the book. I'm impressed. Like a lot of people just read the introduction. Yeah, it was something that I think I learned along the way. I was collecting examples of what works? Like, where are the solutions and why aren't we using them? And what stunned me was how some of them are in fact so incredibly simple. The friendship bench was developed in Zimbabwe by a young psychiatrist, very talented guy named Dixon Chibanda. And Dixon, about 10, 12 years ago, was faced with really just a tsunami of mental health need. And there were only 9 psychiatrists in the entire nation of, I think, 30 million people. And so he figured he had to find a different way forward. So he started using grannies, older women in the villages who were very respected and who had a lot of experience. And he trained them to do sort of basic cognitive behavior therapy. And in front of every clinic, they put out a bench where the granny would sit. And then mostly it was young women, often young pregnant women, would come and talk. And sometimes once, sometimes repeatedly. And they finally did an actual controlled trial and looked at this. And it was stunning that the impact of having this friendship bench was enormous. In fact, it was like you could see it at a population level. The villages that had a friendship bench had far lower levels of postpartum depression and a bunch of other problems. As I've said since then, if the friendship bench were a pill, it would have been a blockbuster. But it's actually even simpler than a pill because it doesn't require a lot. Now, New York has tried it. London, a bunch of other places have exported this idea or imported this idea and try to develop the same concept. And it may not work as well in other cultures where grannies don't get the same respect, but it's an example of what we should be thinking about, that there are solutions that aren't super expensive or very complicated that we can actually begin to scale. And some of this has to do with, like, what do we value and what do we care about and where do we want to put our energy and what kind of a society do we want to be? But don't forget that we have good stuff to offer. We're just not offering it. And that's the piece that I think the book is really trying to call out.
Well, thank you, Tom. I look forward to continuing the conversation tomorrow in our grand rounds with Rhonda. And I'll end it here with Lonnie opening up the Q&A.
What a extremely thoughtful conversation. We can't get to, of course, the answers to these very excellent questions that have been coming in. A couple quick thoughts. One, David, could you give us the 30-second elevator pitch about what is tomorrow? What do you and Dr. Insel and Dr. Robinson-Beal tell us what you guys are going to be doing the grand rounds? A quick note to everyone, grand rounds is open to anyone, not just clinicians. So if you want to hear more and maybe hear more perspectives, you can register for tomorrow. So David, give us the 30 seconds on it. What's it going to be tomorrow?
Bringing in a powerhouse in Rhonda, who's a colleague of Tom, who's just fantastic. And the goal is to bring another perspective, another part of the system that needs to be brought in to solve these problems. And we'll continue the conversation and hit on a lot of things that we didn't talk about tonight. But we need to bring in a perspective from the payer, Tom representing government and tech, and myself being a provider. So very excited and a lot to cover tomorrow.
Okay, good. Thank you so much. I want to remind folks, we are going to be doing a random drawing of people who are on the Zoom to get a free copy of Dr. Insel's book, courtesy of both Fan and Dr. Schreiber. Tomorrow, the clinicians attending grand rounds will be getting a copy of Healing as well, courtesy of Compass Health Center. So thank you so much for that. Looking at the government piece, there's a couple questions I want to get to. I am going to take a look at the upvotes. We have Representative Jennifer Carlson is on the Zoom. She's asking, and her question was upvoted quite a bit. Will Dr. Insel work with, or is he already working with, state legislators who are trying to work on solutions?
Certainly in California, that's where I've spent most of my time. I was in Massachusetts last week meeting with legislators there. The hot thing right now legislatively is 988. And hopefully people on the call know about that. 988 is the new mental health crisis number that goes into effect on July 16th. I wish that 988 by itself would solve the problem. It's really the beginning of what is a transformation of how we handle crisis. I said before that what I think is so egregious is the way people get incarcerated. Well, that happens because when you have a mental health crisis, it's likely to be the police who come to respond. 988 is a different number that hopefully will send mobile crisis, social worker, nurse, peer. And if you do need to go someplace, you don't go to jail, you don't go to a medical surgical ER, you go to a crisis stabilization unit. So I think the legislative fix right now is to put all that in place, that continuum of someone to call, someone to come, someplace to go. We have to build that out across the country, and definitely think that there are good models to deploy. So we know how to do it, but we haven't paid for it, haven't built it everywhere.
Okay, good. And we have about 2 minutes left, so we'll tuck in a couple more questions. Elizabeth says she loves the idea of having a team. How do we begin to change this in the US?
Well, it is changing in places. I think where I'm most excited is to see the involvement of peers. And again, if the problem is not just access, but engagement, particularly for those with the most serious forms of mental illness, then bringing in people who can help with engagement, and that does require a team, is going to be really important. The team's got to be kind of broad. It's not just mental health people. We need expertise in physical health. We need people who can help on the whole social support side, housing. A lot of these people have food insecurity. So, and even thinking about income inequality, which is a big issue. Poverty is a huge issue for what happens to people with serious mental illness and why they die early and why they have so much in the way of health disparities. That's fixable. We know actually how to deal with that. So lots of opportunities here, but it does take a team.
Well, I know tomorrow, David, I am traveling out of town tomorrow, so our director of operations is running the Zoom tomorrow. I wish I could be there to see it live. I want to encourage both of you, and for Dr. Robinson-Beal, a lot of questions came in ahead of time and some more during the Zoom. People wanting to know about the role of schools and teachers, and maybe teacher trainings, and the parent-school partnership, and how can parents be brought in? How can teachers be trained to kind of bring up some of these topics when they're spotting things in their students? And I know, David, obviously you work with a ton of schools, so I know you'll have some thoughts on this. So I just want to encourage y'all to talk about that. And then as we're at the now 8 o'clock hour, I just want to also say, David, I'm sure it was not intentional, but you brought up John Cacioppo, who, as you know, is like my dear friend. And I appreciate that.
You don't
He was amazing. He was an amazing individual. And his program for FAN back in 2010, 12 years ago, was simply stunning. And when you brought it up, I actually got a little bit taken off guard a little bit. So I appreciate that you brought up John, because he's a giant and his work is just transformational. So I appreciate that.
That was the first FAN event I did. I remember we went to dinner together. The three of us.